In this lecture, we're going to be going over quality management, which is really more about you understand QC and why we perform QC. Quality management is the process of establishing, analyzing, improving, and re-examining your quality control processes to make sure that you're actually ensuring adequate patient or actually exemplary patient care. Okay, so in quality management, what you're going to be doing is defining the quality indicators that you're going to be looking at, the measurable quality indicators that you're going to be looking at, and compare those indicators either over time in your own institution or department, or over time, even in a particular moment with other departments, other institutions, you're going to, which would be called benchmarking. So one of the reasons why a quality management program is required in every laboratory is that lab mistakes do occur. We're all human. Mistakes occur, and it's estimated that a lab mistake occurs in about 1 in 1,000 patient visits to a hospital. We're specifically talking about the lab here. 1/4 of those mistakes that occur, pardon me, are judged to have some kind of effect on patient management. So it's really small portion, and even less than that 1/4 would have any effect on patient outcome. It's a bit different to have an effect on patient management, meaning so it might change the way a doctor would treat or keep the patient in-house or something like that, versus patient outcome. Patient, usually the change in outcome would be poor. But because these mistakes do occur, a quality management program is required in every laboratory, and you're going to go through some of the steps here in developing and maintaining one. So when you're developing a quality management program, what you're looking at is a continual process where you look at the standards that are expected for a particular area of the lab. And those standards are provided by our deemed agencies. CLSI is probably our biggest one, AABB, JCO, CAP, New York State. Whatever standards they give us, we identify the standards that relate to whatever procedure we're analyzing, and we select some mechanism to measure something measurable. Okay, you can't say, well, you can't be too esoteric here. You have to say, I need something that I can actually measure, if it's turnaround time or if it's report accuracy or if it's transport time, whatever the measurable factor is for that particular procedure, you have to choose some and be able to compare it over time, watch it change, potentially change over time, because remember, you're trying to improve it. Pardon me. So if and the lab gets pulled into these in other areas of the hospital as well. So for example, if it's a goal to get those patients who are patients come into the emergency room all the time complaining of chest pain, they might not actually be having a heart attack. So identifying those patients and getting them out of the hospital quickly is an important goal. It helps get, nobody wants to be in the hospital too long, and it reduces cost for the patient as well as for the hospital. And it improves our outlook with our deemed agencies. So getting those tests that would demonstrate whether a person was actually having a heart attack or not are important. And so retracking them, the lab gets pulled into these things. We want the phlebotomist to collect these specimens earlier. We want to get these specimens run earlier, validated earlier, and reported to the floor earlier. So then we can turn these patients around. If they're not having a heart attack, why would we keep them here? That's an example of something, a goal that the hospital sets for itself, and all the relevant areas of the hospital that can help in achieving that goal will be brought into that particular standard improvement protocol. Within the lab itself, there are performance standards that we would, do we want to improve our, or reduce, let's say, our the number of corrected reports that we have. There might be some area where we're validating and reporting results too early. Well, if that's the case, then being able to measure how, the time between processing, running, and validating, is there some place there where more attention can be paid so that corrected reports don't have to happen? These, it could be any aspect of the lab that could be drawn into any kind of performance improvement plan. It could be from the pre-analytical where, are the doctors ordering the right tests? Are the patients being prepped right? Are the specimens being collected and transported properly? Patient identification has been a big one. That's that JCO initiative to make sure that we identify patients properly. And all the processing steps that might have to take place with any particular specimen. The analytical portion of the lab, this is where we spend an awful lot of time with our QC. We do an awful lot of QC on anything that's analytical, as you know. We keep lots and lots of records. But there's a good reason for that. We need to ensure the reliability of our instruments, our procedures, our reagents. And the reality is that with all the attention that we pay to the analytical portion of the laboratory, it's actually the lowest number of errors occur in this particular section of this area, we'll say, of the laboratory. The pre-analytical, patient's not prepped right, storage problems or transport problems. Post-analytical, something was reported incorrectly or interpreted incorrectly, something that's very hard to convince doctors to change their thinking on. Or maybe they're even using the information improperly. That's a possibility as well. Those are all areas where improvement can take place, and it's part of what our education and our continuing ed programs hopefully will allow us to communicate with the doctors. One of the things that's important to remember, we know that there are these three areas: pre-analytical, analytical, and post-analytical. But the reality is there are areas that cross over. They cover more than one area. So turnaround time is a big thing. Hospitals always complaining, we want faster turnaround, faster, faster, faster. Which sounds great, but haste makes waste. Turnaround time would involve all three areas of the hospital, making sure that the specimen gets there on time. The analysis takes what it takes, getting it in the queue faster, and then reporting it faster. All of these things can be improved potentially, but without losing the sight of the quality of the result that we're providing. Otherwise, those corrector reports, I said, those would be increased if our turnaround time was too extreme. There are these two tools that are provided. They're actually products of CAP, and they're management tools. And at this point, you know that every area of the lab has to participate in proficiency exams, and those proficiency exams allow us to judge our performance against the performance of any other laboratory doing the same test with the same instrument or procedure. Well, the CAP also provides these management tools called Q-probes and Q-tracks. They're benchmarking tools which allow you to compare your quality control program, your quality management program, with the programs of other hospitals. It's very difficult to say if we have a good one or a bad one if we've never seen anybody else's. Okay, so Q-probes is it's a series of QA studies, quality assurance studies, that CAP will send you and then it's evaluated by the peer hospitals in your area, and it allows you to determine if the process that you applied to the study would be an appropriate process, or is there room for improvement? And then Q-tracks is another tool that allows it provides continuous quality monitor for tracking changes over time. These are just tools that are sold by CAP that you could potentially participate in. You might participate in them in your hospital. These are a supplement to a quality management program that you've already developed, and it lets you know if your quality management program is up to snuff, if it works well. Now, when we're looking at quality management and how we can ensure good quality in all areas of the laboratory, we have to look at our targets. In the pre-analytical area of the lab, what are the targets? What are the things that we can either increase education on, increase reliability on, timing, and all that stuff? Well, with the test ordering, for example, how do we control, what role do we have in ensuring that the best tests are ordered for the patient conditions that we see? Well, ensuring that the doctor understands the indications for the particular test that's ordered, whether it's the right kind of specimen, whether it's the right kind of diagnosis. You know, if a patient comes in with a respiratory complaint, why would you be ordering a C. diff? What are the indications that imply that C. diff might be an issue? I remember a physician calling once. The physician had ordered an ova and parasite exam on one of her patients. It was a child in an HIV clinic, and the tech who read it saw, I don't remember what the parasite was, but the tech saw a parasite and reported it. Parasites were not considered and are not considered critical result in the hospital that we worked at. In some hospitals it are, but in that hospital it wasn't. Now this was a clinic patient, so that means the patient comes in once a month in this clinic. That's the way it worked. So let's say the test was ordered in June, patient comes back in July. That's when the doctor really reads the results. And so it was in July when the patient returned that the doctor sees the result. And of course, we don't have the stool anymore. At that point, it's a month later. So when she calls me to see if I could double check this, I have no means of double checking it because we don't have the stool anymore. We don't save them. And the doctor told me it doesn't make any sense to her because the patient doesn't have any history of travel that would correlate with this parasite finding. And I said, well, what the heck did you order O&P for? If the patient has no risk and no history, why did you order it? Sometimes the doctors have to be aware, you know, you order at your own risk. Now you have the information, now you got to do something about it. There's definitely a laboratory role in controlling the frequency with which tests are ordered, as well as who orders. The tests are supposed to be ordered only by the physician who's caring for the patient, but clinical personnel really is supposed to be the physician. It used to be that the physicians never ordered any tests. The physician would write the test that they wanted in the chart. The chart would go to the clerk, and the clerk would order the tests, which was, of course, an area that was rife with errors. And that's why the rules have changed, and the physician has to order the test. Can a nurse order a test? Yes. Can a nurse practitioner or a PA order a test? Yes. They have to be a clinician. The clerk shouldn't be ordering anything. So if a clerk calls you and says, I'm trying to order, they're not supposed to be ordering anything. Some of the rules that can be placed in place in the laboratory are things like reflex tests and cancel tests. A reflex test is a test that is automatically ordered based on the results of some other test. So a patient has a screening test for Lyme's disease. If that test is positive, it reflexes, and you end up the order for the confirmatory Western blot is automatic. You don't have, the doctor doesn't have to order both, and should just order the screening test. Cancel test also. When a test is ordered, it doesn't necessarily mean it's collected. So the physician orders it, the phlebotomist or the nurse goes in to collect it, and the patient says, no, you're not collecting that from me. Or there's some other reason why the specimen can't be collected. that test technically should be ordered, canceled, since it was ordered on that day for that day. While those collect dates can be changed pretty easily, the test itself tends to sort of hang out on our pending log until the patient is discharged, and then we feel, oh, I guess we can get rid of that test, because technically it's supposed to be canceled by the physician. At specimen collection, we certainly have a big role in ensuring that the patient is identified properly. You know the labeling rules for the specimens, but also making sure that the patient, that the clinicians who are collecting these things and the patient understand what the proper collection container is and the procedure to do that. All that information, the collection, the procedure to collect, what type of specimens are accepted, how you should transport it to the laboratory and store it, and the timing, how often the test is run so that they can be collected most appropriately for the timing of the test. All of that information has to be provided to every clinician in a manual. In most hospitals these days, the manual is available on the intranet of the hospital so that any clinician who's in the hospital can access it, and that lets them know every single test that's available that they can order through the hospital, and then what's required for that order, how often that test is run, all of that information is there. The pre-analytical quality management programs, the measurable data, or the data that we get to analyze these pre-analytical parts, come from several areas. Obviously, there are measurable things like delays and temperature problems with transport mechanisms or lost specimens. All of that stuff is measurable. Have we lost a lot of specimens? Has there been a big delay? And all that stuff we can look at. But the other place where we get information is from patient or client satisfaction surveys. These are things that we're required to give to our patients, and our remuneration, our payment for services will be dependent upon the score, the average score that we get from all of our patients. And in the patient and client satisfaction survey, there are objective and subjective areas. You know, we can ask the patient, how long did you wait? That's a number. That's an objective number. What were you here for? We can relate that number to the diagnosis or the symptom they were here for. Were there any complications? That's a yes or no. Either there were or there were not. How many needle sticks did you have? How many times did you have to undergo phlebotomy? It's one of the things that makes patients very cranky. How clean was the area that you were in, wherever it was? These are all things we're getting input from outside people to let us know how we're doing. And they're all areas which actually lead to a lot of patient dissatisfaction. So making sure that we optimize the patient's experience in these areas tends to improve our patient survey scores. Now, just so that you have an idea of what the standards look like, these are examples of some of the standards for the pre-examination procedures. These are just a couple of them that I found. And the way that we read these is you have the standard on the left-hand side, and then any guidance that the agency is giving you, and this is from CLSI, any guidance that they're going to give you is on the right-hand side. So you can see what's the standard that applies to an oral request for a test from a physician. Well, if the physician talks to you and asks about a request to the laboratory, we have to receive a written request in the laboratory within 48 hours. If we don't, then we notify the physician, hey, we didn't receive that. Okay. And you can see, so there has to be some procedure in your manuals which demonstrate that you are allowed, if you are, to receive an oral request and what the procedure is that goes along with that. And that procedure must include this requirement that within 48 hours you receive a written request. If you talk about the instruction manual, so this is that thing I was talking about, how all the proper identification, handling, transporting of specimens has to be maintained within a manual. It has to, in that manual, it has to have every exam that the lab offers. If there's a consent form, that has to be in there. Instructions, how do I prep the patient? What those things as far as collection, that all has to be in there. And then what kind of methodology do we use for that? For that particular test, and do we do it in-house or out, and so on down the line. And then you can see you keep going, or you have lots of more, the procedures for identification and collection, instructions for making putting the order in the computer, how much timing, all that stuff has to be kept in a manual. And again, most hospitals keep this manual on the intranet. It used to be, it had big binders and they had to be on every floor and the whole bit. As we said before, the analytical quality management is probably the largest area of quality control, of quality management programs within the laboratory. And rightly so, there's a lot of information, a lot of moving parts. And it starts before you ever even have the procedure up and running in the lab. It starts with method evaluation, method selection, which is where you're trying to decide if a particular instrument or procedure, if you can bring it into your laboratory. And there's 3 stages where of method selection, of method evaluation and implementation. Stage 1 is where you actually have to, so you've made a choice. You said, I think I'm going to try this procedure. You have to document the procedure. You have to have a written procedure, obviously. And you're going to do a lot of testing runs. You're going to be validating the linearity of the machine and calibrating the machine and all that fun stuff, creating all that quality control data. And from that data, you're going to be able to determine any kind of run imprecision that might exist in the procedure, and evaluate those runs for any kind of interferences that might exist. And it could be something simple like, okay, if we bring in this instrument, it doesn't fit in this corner. That's something that you do have to figure out in this whole process. Yeah, it fits, in this corner, but running it and being in this corner, it doesn't work in the lab. So it has to be everything from where it's going to fit in the lab to how it actually runs, so you're getting good results for this, for your patient population. Once you have all that information, then in stage 2, you're going to start sort of branching out a little bit, and you try to determine day-to-day imprecisions that might occur. So this helps you to establish what kind of daily QC needs to be run. I'm thinking of an instrument now. What kind of daily QC needs to be run? So, okay, day to day, the lenses get cloudy or dusty. We need to clean those every day, and then we remove that imprecision. What are the other things that you might need to do? You also, at this point, have to be able to compare the accuracy and precision of this new method with any old method that you might be running, if that applies. If this is totally new and it never existed before, that's different. But if there is a new, if this is a new procedure or instrument that's replacing an old one, you have to compare the two and evaluate, is the bias, is the imprecision that we do see, whether it's within run or from day to day, is that acceptable? Is that something we're okay with? And then you also, at this point, also you have to kind of perform and validate your reference ranges. Most kits come with reference ranges sort of built in, but remember, every patient population is a little bit different. So you probably want to run on your population to validate that the reference ranges that come with the procedure are accurate for your group. Then once that's done, you're moving on to stage 3. In stage 3, you're going to finalize or establish the final QC ranges that exist, right? The critical values, any delta checks, establish those within the computer system and train your personnel to use the new procedure and how it would work in your hospital. Then once that's done, you can complete and sign off on any procedures, you as the evaluating person, as well as anybody who's trained on it. And then you start notifying doctors, okay, finally we have something new that you can run on your patients. That's before you ever even run one patient specimen. You've done all this work, okay? So that's a lot. Then once you have it running, you have your normal, regular, daily quality control that you have to run. That helps you to monitor that, okay, I know it's supposed to work this way, and make sure that it keeps working that way. And when you do that, you're probably going to have lots of more data that you're going to be looking at, and you're going to have Levy-Jennings charts that you'll be able to apply, hopefully, to the processing. Okay, the Levy-Jennings charts can be analyzed. This chart here is just a sample of the Levy-Jennings rules, or I should say the Westgard rules, that you can apply to any Levy-Jennings chart. And you have to decide in your lab for that procedure which one of these rules most applies. Okay, we want ones that can detect random error. We want ones that can detect systematic errors. And is the systematic error that we can, is it a large systematic error or a small systematic error? And you can see that each of the rules, they do a little bit different job. Okay, so which ones do we use the most? The one that's most used is the one 2SD. That's probably the most commonly used one. It detects a random error. For the most part, it'll be random error. And probably at this point, it's probably considered mostly overused. It will be considered warning. You don't have to reject the run with that, but it's a good warning rule. At least that's what laboratorians believe. But you can see that there's a whole bunch of other rules, and you would need to choose amongst these rules and see which ones you're going to apply to your QC data. Then you're going to have to decide how frequently you're going to test QC with this new procedure. Are you going to do it each shift? Are you going to do it for every test personnel that uses the procedure? How often are you going to do this? Okay. As a general rule, CLSI wants to see you do it more by the throughput instead of by the clock. So maybe you'll run QC every 300 tests or 100 tests to ensure that you catch any errors that might be occurring more rapidly. The benefit of doing that, although it would cost more in reagents, the benefit of doing that is that when an error does occur, you have to rerun all of the samples since the last QC that was in range. And if that is the case, you'd be rerunning a lot more samples if you waited too long to retest. Then there's this phrase MAE, specification of MAE, which is the maximum allowable error. Specifying maximum allowable error provides information about the adequacy of any analytical system for patient care. Basically, it represents the total error that your institution will tolerate, or that any institution would tolerate without invalidating the usefulness of the test. Okay? Basically, the MAE is used to set goals for the analytical performance of a test. As long as it's performing at a certain point, then we can accept this procedure as useful to our patients. And we'll get a little bit more to that in the next. It required some more charts that I have to move on to the next one. Just to say a couple of quick things. Your patient QC refers to patients within patient runs. So for example, you get a really strange result. One of the first things that we usually do is rerun it to ensure that it's actually a correct result. Although that happens less and less frequently these days as our instruments become more and more precise. But also with some analyzers, they run the patient in duplicate, so the test is performed twice, whether you actually aliquot twice is usually not necessary, and that allows you to for a test that has has a fairly large random error, um, by analyzing it in duplicate and reporting it as an average, it helps to eliminate some of that error that might exist in the test itself, in the test platform itself. And then also there's the requirement. Oh, just to also mention, if you have multiple analyzers, or you do the procedure, or whatever the procedure is, if you do it in more than one place. So for the best example is analyzers. So if you have an architect chemistry machine in the Gen Lab, but you also have one in a stat lab and also at some satellite site, you have to actually perform QC to ensure that all three of them are running within acceptable ranges. And that would involve splitting samples randomly, you can't do it retrospectively. So you'll get some kind of flag every once in a while, say, okay, this is a specimen, Joe Smith's specimen just came in. He's just randomly flagged, split his specimen 3 times and send it out. We'll run it on his Chem 7 on all 3 and make sure that they actually match. Okay, that's required when you have more than one analyzer or procedure of the same type. And then you also have to establish a delta check where you're looking for changes in individual patient data. Make sure that it doesn't change too much, that you can accept the physiological change over time. Now, just to go back to MAE here for a minute, MAE can be related to an imprecision number, the percent imprecision, developing an MAE imprecision ratio. As a general rule, the higher the MAE is, the less useful the test is considered. So, for example, sodium has a ratio, an MAE imprecision ratio of about 1. So any 1% shift in a measured sodium might make the measurement too inaccurate for it to be considered useful. Okay, and that should kind of make sense, since, as you know, serum sodium levels are pretty tightly controlled physiologically. Okay, when we get tests in, the manufacturer has to tell us what the MAE imprecision ratio is. And anytime that ratio is greater than 2.5, generally speaking, what we're looking for is for the manufacturer to decrease the imprecision of that test. It's not necessarily always possible. There might be actual built-in imprecision to a particular test. But when you're seeing it, greater than 2.5 improvements are what we're looking for. Okay, and so you can see when you have these ratios, look at the control rules that are going to apply to that. If your ratio is between 2.2 and 4, between 2 and 4, you can use a couple of the rules from the Westgard rules would be sufficient. 2 or 3 control levels at startup and shift changes. And then if you use the 3SD and 2,2SD as well as the R4SD rule, you should be fine with dealing with that test. As the MAE imprecision ratio increases, you can start to see the change in the Westgard rules that will apply to it. These are some more standards that exist. You can see there are a bunch of different, I just want you to see how to read these standards. So again, on the left-hand side, we have the standard and any guidance on the right-hand side. So this is a hematology standard 4. Here's your automatic coag procedures. You need 2 levels of QC to be run each 8 hours of your QC, and also anytime you change a reagent. Okay, so that has to be demonstrated in your procedures as well as practically. You need to have evidence that you did do this every 8 hours. That's the minimum. If your hospital decides to do it every 4 hours, then bully for you. That's what you're going to do. For manual coag tests, these are manual, so this is an automated coag test. For manual coag tests, which almost nobody does anymore, you have to have, again, every time the test is performed, you have to have 2 levels of QC prior to the patient results. Remember, this is manual, and every time your reagent is changed. This is a standard in microbiology. I mean, you can see that these are just different examples of the same thing. This is one for QC of commercial media. We have to test all the media for the way that it functions, to make sure that it functions the way it's supposed to be, with few exceptions. There are, I shouldn't say there are few, there are some that we have to directly test, and you can see one of the things that we have to look for every time media comes in. We have to look for cracks or unequal filling, changes in hemolysis, bubbles, freezing, those kind of things with the media as it comes in. In blood bank, you can see here some more standards. If this is for the AHG, if you get a negative reaction, or I should say, if you don't see a negative reaction, an investigation shall be performed and controls shall be run. So there's clear rules, and these rules have to be a part of the procedures in your laboratory. Again, just another example of this is QC assessment improvement standards. So this is for repeated analysis. If you have a proficiency test, no repeat analysis. That's what it says. So in your procedures that apply to proficiency tests, it has to say that you do not repeat the analysis. Okay. Now you can use it for another reason. So you can split a sample, give one to lab technician A and another to lab technician B, and that's what a lot of hospitals do to get sort of around this rule, because they want to perform it more than once. And you can see, you go down the list, you could read these. It's just to get, I just want to show you what they look like. These are the things that you'll be wading through before each inspection. Now, post-analytical procedures, again, there's standards that apply to that. You have here the standard that applies to records retention. So you can see, here we go, tissue pathology, cytology, how long do you have to keep them? 20 years. Syphilis, how long do we have to keep them? 2 years. Cytogenetics, 25 years. All others, 7 years. Okay. A lot of times what happens is we keep them for, it's kind of hard to separate all of them. So we might keep the lab ones for 7 years, including the serology, and then just throw it all out at the end. You can keep it longer, you just can't throw it out early. And this goes down, you have to keep the test requisitions, accession records, test procedures, analytical system records, including any worksheets, and so on down the line. This continues. The things that we're really talking about with post-analytical quality management, turnaround time is always going to be part of it. Of course, that includes the other areas, but the turnaround time is measured from order to result. That's what they're looking for. How long does it take me to get my result once I order it? Then other things that they're looking for: corrected or incomplete reports and document control. These are all things that have to be measured and maintained. And then this is just another standard, again, just to give you an idea of what they look like and how to read them. Non-conformity sustaining. This is really just an example of when the exams that you have, what happens when something doesn't follow your procedures. What are you supposed to do? So this is really how your incident reports controlled. This is telling you you have to have incident reports. So somebody makes a mistake, somebody doesn't follow procedure, you have to do something, okay? That's what this standard is saying, okay? You're not allowed to just say, oh, she'll get it right the next time. Okay, point of care testing, quality management, point of care testing. There's absolutely, this is one of the areas of the lab which is such a bear to deal with. Dealing with our own QC, hard enough. You always have the techs who never fill in the temperature sheets, or they forget to put, the QC on or whatever it is. But at least they're there and we can yell at them, okay? With point of care testing, we don't actually control that instrument. We don't control it, but we're still responsible for um, the quality control for it. So if you look at them, there's a lot of challenges throughout the history of point of care testing. Um, Gaining access to the analyzers, and some of the biggest ones are the glucose monitors that are used on the floor. All of those things. Those are at point of care. The INR monitors, all of those things. We need them back. We need to see them and get them. They can't just disappear, and unfortunately, sometimes they do walk away. There's a little bit of sense of competition between the point of care personnel and the central lab. We don't think that they know enough. They don't think that we know enough. The whole thing. And then who's supposed to pay for that? We're in charge of QC. It is a lab test, but we don't get to control any of it. So, is it cheaper? Is it really cheaper? With all the paperwork that goes on around the institution. And then who's in charge? Is the nurse really the one who's in charge, the one who hasn't been trained to do these tests, or should it be us who are in charge? This will always be a problem in the hospital. So this chart gives you a pretty good idea of what the challenges are with point of care testing, whether it's operational or organizational or technological. Okay, so point of care oversight. There should be some pretty basic goals of the management of point of care. First of all, the idea of point of care really is to improve the quality of patient care. Okay, the idea being that faster care is probably better care. Is that arguable? Probably, but um, it's a generally accepted lifestyle, we'll say. And that patients who feel like you're doing something right away, they tend to be more satisfied. Not just patients, also the physician and the nurse. They don't have to wait for the result. Okay. A lot of times it can shorten the patient visit and you can get them turned around and heading home, educated about their illness much more quickly. But the things that we have to consider are the practical things. Are we accredited for point of care? Accreditation is a step for everything. We have to make sure that our staff who are using these instruments will be accredited to use them and that the lab is able to still control them. We have to fulfill all of our state and federal regulations concerning these point of care instruments, and that helps us to decrease our liability overall for when we're using them. The practical considerations are probably the hardest. Who's actually going to perform the test? Should it just be lab staff? Should there be a phlebotomist who knows how to run this thing and the phlebotomist does it? Should there be a tech on hand or an MLT? Or is it going to be the nurse? Is it going to be some kind of clerk? Is it going to be the physician? If it's another staff, they're not under the auspices of the laboratory. So how do we control the procedures that they follow, and how do we reprimand them if they do not follow the procedure properly? What's the whole point of putting the point of care test there? Like, what is the institution trying to achieve? Sometimes that's the hardest thing to define. People think, well, let's get glucose machines for the ER so they don't have to wait for glucose from the laboratory. Okay, well, how is that better? How many patients that come in only need a glucose test? There's nothing else. So that becomes, think through the problem before you come to the solution. And again, the licensure and accreditation is different. If you don't gain a license, then you're running off of the license of the main lab, and that can be tricky. So making sure that each site, if necessary, has their own license. That means that they perform their own proficiency exams, and they have their own procedures and all that stuff. So this is the last slide here on the International Organization for Standardization, or IOS. I'm sorry, it's actually deemed ISO. This was developed in 1947. It's a non-governmental association that has representatives from over 150 different countries. Basically, you got one member from each country. And these guys work to achieve some kind of technical consensus for the standards. They have all kinds of committees and working groups and stuff like that, and they're looking for some kind of professional consensus about the quality of a particular of any particular procedure or instrument, or what have you. Membership is voluntary, it's not required, and it doesn't ensure that the products made by any particular, a lot of these are manufacturing companies that are members of this. It doesn't ensure that the products are ideal or standardized, but lots of companies do join the manufacturing companies do join this group because it demonstrates that the company at least follows the procedures that have been already agreed upon. Okay, you know, one of those things that's easier to change from within than change from without. So these manufacturers become part of the group so that they can help to direct the field. And ISO, the standardization organization, has several quality management systems that are in place, and there's a few that I want you to know. ISO 9000 is the most widely used quality management system, and it contains 8 principles. The 8 principles are leadership, customer focus, a process approach, a system approach to management. It involves the people who it will oversee. It requires facts to make decisions. It looks for continual improvement, and it should emphasize a mutually beneficial supplier relationship between everybody involved. Okay, those are the 8 principles for ISO 9000. Then they came out with ISO 9001, which is this little short document which describes a series of like must-haves for any quality system, but it doesn't go into detail about those requirements. Should be like how they should be carried out or how they should be approached or anything like that. Basically, what ISO 9001 does is it says that quality objectives have to be measurable, and they have to include those needed to meet the requirements of whatever the product is that you're putting out there. It requires that that there be some kind of quality manual that will that has all the procedures. Of course, that's something that most of the deemed agencies will require. And it says that the quality manual should be updated, so it's not one of those things where you create it and it sits on a shelf gathering dust. It has to be a continual process. In ISO 9001, there are 6 procedures, written procedures, that are required. It requires a procedure for the control of documents, a procedure for the control of records, or data sets, a procedure for internal audits, for control of non-conforming products, a procedure for corrective action, and a procedure for preventative action. Those are 6 things: control of documents, control of records, internal audits, control of non-conforming products or processes, corrective action and preventative action. The ISO 9001 requires a regular review of your objectives and any output that you have from the in terms of resource provision, improvement to the effectiveness of QMS, all that stuff. Okay, mandates activities that will assess the competency, training, and awareness. Then we have ISO 15189, which was established in 2003. That's based on ISO 9001, and as well as a second standard called ISO 17025. And these two were meant specifically for medical labs. So these are much longer documents than the 9001, and they're very detailed. They have a lot of the technical requirements and the medical requirements included in them. Pardon me. But it also relates to and refers to all of the quality management system requirements of 9001. So these three documents together would be used to help develop and maintain quality management systems in the laboratory. So what are the requirements that are there? ISO 1589 is divided into 5 sections for 5 domains. Domain 1 is the scope. Domain 2, what are the normal references? Domain 3, the terms and conditions. 4, the management requirements, and 5, the technical requirements. The bulk of the document it consists of the management requirements in the sections 4 and 5, management and technical requirements. And so these are the sections that we use in the clinical laboratory to assess our procedures and our performance. So this is just an example of, you might hear of it like on a test or something like that, of documents that have been produced by this organization, ISO, which apply specifically to the clinical laboratory and how they should develop the requirements that outline the development of their quality management systems.